Hi, I'm Dr. Andy Barlow with the American Functional Neurology Institute, and I can be reached at AFNIseminars.com. My phone number is 662-844-1414. I'm in private practice with Dr. Matt Mackey of the Chiropractic Neurology Center of Tupelo. Today, we're going to be talking about a neurological exam. While we're doing our neurological exam, we're looking for what is called in neurology the longitudinal level of the lesion. And today we're going to be talking about small diameter afferent neurons. Another way of saying that is pain fibers and pain pathways. So when we're talking about the small diameter afferent neurons, these pathways, they're made up of two receptors that are called free nerve endings. The first receptor is what's called A delta fibers, and the second one is what would be called C fibers. Now the A delta fibers are myelinated. They're a little bit faster pain pathway than the C fibers. So like example, if you step on a nail and it's out, that immediate type of pain. Or also we may get sharp shooting pain. These would be the descriptions that a patient would give us of a delta fiber that's firing. Also your A delta fibers, you can actually take your finger and go, Doc, it's hurting right there, or it's right there, or it's right here. And that's more of an acute type of problem. You can localize it, you can kind of pinpoint it, and it's burning. When you have, it's a sharp shooting type of pain. Now C fibers, they're unmyelinated, so those are going to be dull, achy, boring types of pain, and it's like, man, my neck hurts like all through here, or my shoulder is like here, and my hip hurts like right in here. Now remember, A delta, you can pinpoint it. C fibers, you're not going to be able to pinpoint the area. So what happens is we need to be able to draw out this pathway and know how this free nerve ending actually gets to our brain, because in a neurological exam, we're going to have to test this pathway with a pinwheel. So what we have here, these receptors, they're free nerve endings. They're going to fire into what is called the dorsal root ganglion, and then it's going to fire into the spinal cord. It's going to fire into the dorsal horn, or the back part of the spinal cord, into mainly into lamina 2. In lamina 2. Now at lamina 2, what's going to happen is this is going to decussate. This is called the anterior commissure. The reason it's called the anterior commissure is because it's anterior or in front of the spinal canal. A commissure means that we take information from one side of the brain to the other, or one side of the spinal cord to the other. So anterior commissure. This is going to fire up the anterolateral system. Once it fires up the anterolateral system, this used to be called the spinal thalamic tract. The reason it's no longer called that is because we know now that this pathway is going to also fire into the medulla, the pons, and as well the mesencephalon. Actually, this pain pathway, 90% of this is actually unconscious, and it's going to stop right here in the mesencephalon, pons, and medulla. Now the reason this is important is because this nociceptive input into the pons and medulla, this is where our cardiac, our respiratory, and gut function centers are located. So you have a person that's in pain. They're going to have problems with their cardiac output, respiratory output, gut function. So if you can figure out a way, which we do neurologically in our clinic, to inhibit this pathway, their heart's going to work better, they're going to be able to breathe better, and their gut, they're going to have better gut motility. Also, in the mesencephalon, you have what is called the mesencephalic reticular activating system. Now this thing is like an alarm system. So when you're in pain, you have a very difficult time falling asleep, because this pain pathway is firing into this mesencephalon. It's like ding, 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 ding. You are not going to sleep tonight. And if you do get a chance to go to sleep, you won't be very restful. So this is 90% of the pain pathway. 10% of this pain pathway actually becomes conscious, and it's going to fire into what is called the ventral posterior lateral nucleus of the thalamus, also known as the VPL. The ventral posterior lateral nucleus of the thalamus is then going to fire into the brain, into an area that's called the parietal lobe. And the parietal lobe is area 3, 1, and 2. Now we can actually test the integrity of this small diameter afferent pathway by using a pinwheel. And momentarily we're going to go into an exam room, and I'm going to show you exactly how to test these small diameter afferent pathways. It literally, in the real world, should only take you less than a minute to do this entire small diameter afferent pathway with this pinwheel if you know how to do it. Alright, now we're back and we're going to go over how do we test the small diameter afferent neuron. And Forrest has been so kind to allow us to use him as a model. And we're going to start with the face with V1, V2, and V3. And what we want to do is we want to compare the face to the upper extremities and to the lower extremities. In health, we should feel the same on the left side and the right side of our body, in the face, hands, and in the feet. So I would have the patient, I'd say, I need you to close your eyes, and I need you to tell me, does this sensation and this sensation feel the same? And they're going to say yes or no. So in Forrest's case, I'm just going to go through it, so we'll see how we do it. So he's going to say yes every time, okay? All right, so does this feel like this?
Yes.
And does this feel like this?
Yes.
Now the easiest thing to do here is just to actually take their palms and turn them down. Now the axillary nerve is actually right here. So the most sensitive area for C5 axillary nerve is here on the shoulder. So when we test here and here, does this and this feel the same? And of course, we would have them with a t-shirt or gowned with this. And then the radial nerve. So I just come here and test the radial nerve. Does this radial nerve and this radial nerve feel the same? And now we're going to test median nerve C6 and median nerve C6. So does this median nerve C6 feel the same as this median nerve C6? And then this is median nerve C7. Does this median nerve C7 feel the same as this median nerve C7? I do not test the ring finger. The reason I do not test the ring finger is because this lateral aspect of the ring finger is controlled by the median nerve, and the medial aspect is controlled by the ulnar nerve. Don't worry, when you come to the seminars, we'll actually go over that. And I do test the ring finger, or the little finger, for C8. Does this C8 ulnar nerve feel like this C8 ulnar nerve? And does T1 feel like T1 and T2 feel like T2? Now we're going to take this, and we're going to move the arms out to the side. Now, in the peripheral nerves, the lateral femoral cutaneous, femoral, and obturator, they come out horizontal. I'm sorry, vertical. If the patient was standing up, they come out vertical. So we would come over here and say, does this lateral femoral cutaneous feel like this lateral femoral cutaneous? Does this femoral nerve feel like this femoral nerve? Does this obturator feel like this obturator? Now L2 and L3, they're going to come across obliquely. Okay, so this is L2 here and L3 down here. So does this L2 feel like this L2 nerve root? Does this L3 feel like this L3 nerve root? Now we're going to come down to the lower extremities here, and we're going to compare the inside of the leg, and this is the L4 saphenous nerve. So does this L4 saphenous nerve, and I do not touch the patient's leg and pull it up, I'm only doing that for demonstration purposes. In the real world, I would say, does this L4 saphenous nerve feel like this L4 saphenous nerve? And then we're going to come across the heel to the big toe, and that's L5 superficial peroneal nerve. So does L5 superficial peroneal nerve feel like L5 superficial peroneal nerve? And does S1 sural feel like S1 sural? And we're going to test that, again, face, arms, legs. We should feel the same on the right and left side of the body. If we don't, we have some type of sensory discrepancy. We have to find out exactly why this person has a deficit with this large diameter afferent neuron. So, and we need to know, where do these receptors come in, where do they decussate, where do they fire to in the thalamus and in the brain. And actually there is a specific type of therapy, a couple of types of therapies that we would do to actually correct this problem once we found it. So I'm Dr. Andy Barlow with the American Functional Neurology Institute, and again I can be reached at 662-844-1414.